Hello, everyone. Apologies for that. Just a slight technical hiccup, but we are back and ready to go, and very excited to introduce our next speakers, who are William McConnell, who's a consultant respiratory physician at Dorset County Hospital, and Paul Wilding, who's a business intelligence partner at the NHS. And they're going to be presenting on turning insight into action, using data to improve asthma outcomes in Dorset. And I believe William and Paul are ready to go.
Great. Yes, lovely. Thank you so much. It's great to be here. So what we want to do is to talk about how clinicians like me are working with people like Paul who are interested in data to start making a difference. And so what we've been doing is we've been doing this for the last few years of trying to look at data in asthma and trying to improve our asthma outcomes. So this is where we started from. This was the I'm one of the leads for respiratory in the southwest of England, NHS England. And what I've known for the last 10 years or 15 years from the NHS Atlas of Variation is that mortality for asthma was worse where I'm from, in Dorset, than it is in the other ICBs in the southwest, and we're worse than the England average, you can see there. And that had been going on for 15 years or so, but I didn't know what to do with it. I didn't know how to change it or how to make it better until we developed DiiS, the Dorset Insight and Intelligence Service, a database of that allowed us to do some population health management. So what I've learned since 2018, since we've had this database, is how powerful data can be to improve care. So, but data on its own doesn't work. You can have data like we have, but you also need leadership. So you need that data to feed the leadership, the strategy, the priorities, and to have a leadership group that can then act on the data and then look back on it and see whether you've made any difference, do PDSA cycles. And then, but you need access to an army of people who are going to make the difference, to the workforce, essentially. And so what we've got is 18 primary care networks in Dorset, and each of them has a respiratory champion, a practice nurse, who can look at the data, and we can be guided by us to what they need to do to
Can now.
Okay. Do you want to say something about DiiS, Paul?
Yes. So I'm Paul Wilding. I'm one of the business intelligence partners within the DiiS, the Dorset Intelligence Insight Service. So DiiS itself is a linked health and social care platform that provides insights across the Dorset ICS. It contains a dedicated data engineering, analytical and data science specialist teams. We all work together with our partners across the whole of the Dorset ICS. That includes healthcare, local authorities, emergency services, voluntary sector. So we're bringing in data from all of the different touch points and systems and services around the county. This is all hosted in a secure online platform that provides that holistic overview of the Dorset population. And while we are NHS hosted, it's a system tool. So it gives those across ICS insights, and it allows our users to consider the whole Dorset population and not just the population that they serve or that they're working with specifically. The DiiS data is pseudonymized to keep it anonymous, and it can provide insights at various different levels. So we can look at the top level, so at ICB level, PCN level, surgeries, down to individual person levels. And so today's presentation with my colleague Will on here is going to demonstrate how he was able to utilize this level of data to be able to call on those evidence-based insights from this level of information to achieve better health and well-being outcomes for our population.
Thank you very much, Paul. And so we've used the database for all of these things that I can see in front of you. To see where the variation exists. We've been able to look at trends over time, and which will judge the effectiveness of what we can do. And we've been making associations, saying if we increase this in inhaler use, is that likely to make an improvement? And look at associations like that, and predict future demand, so that you can then put in business cases to say, well, if we do this, spend a bit of money over here, it's likely to have this sort of benefit. And then from the workforce point of view, it's really useful to re-identify those pseudonymized numbers into NHS numbers at the primary care network level, so that they can start doing the work and changing patient care. So this is one of our metrics for asthma, which is quite important, which is the over-reliance that some people with asthma have on their blue inhalers, their salbutamol, short-acting beta-2 agonists. And what we don't want is them using more than 6 of these inhalers a year. We want them to be using their preventative inhaled steroids instead. And what's happened over the last 3 years, this is national data looking at where we were in 2022 and 2025, is that there's been improvement in all of the regions of England in terms of SABA use. But the biggest improvement is in the southwest of England, which is where we're based, and where we've now the best performing in the country from this particular metric. So that's great. And we have to remember that SABA overuse is linked to mortality, which is what I was talking about earlier. If we look down at the 7 ICBs within the southwest, we can see it varies quite a bit. Here's the Cornwall, where they do overuse SABAs quite a bit, 23, 20, down to 19% of their patients are using 6 or more SABAs a year. And other places, everywhere's improving, but there are 2 places that are improving faster than others. Gloucestershire here, which is improving quite significantly, so it's one of the best ICBs in England for this, and this is Dorset, where I'm from, and we're getting better quite quickly, but we're never meeting Gloucestershire, which is a bit irritating, but it's not a competition, but we would like to be better than Gloucester. So anyway, so that's what we've managed to do over the last few years. The question is, how have we done it? And we've done it. The thing that Gloucester and Dorset have got, we've both got networks of respiratory clinicians with leadership. We've both got data sets that we can look at, and we've both got access to the workforce. And that's what we've got that those other ICBs haven't. And this is our DiiS, it's one of my favorite DiiS pages, looking at our asthma treatments, and this is what we call SABA overuse. This is people with 6 or more SABA. So you can see that, the majority of people, 30% of people, don't use SABAs at all, and then 12 or more, this is terrible asthma control, so 2.5% are using 12 or more. And these are inhaled steroids, so these are the preventer inhalers. So what we want is for the SABA use to be down here and the inhaled steroid use to be up here. But there's a distribution. And then linked to that, we've got this. And so this is our respiratory admissions for our asthma population. And you can see that, that we're talking about in whole of Dorset, about 60,000 people with asthma. And so if you're talking about 2%, that's still quite a lot of people. So those are our asthma admissions, and here we can see prednisolone prescriptions. So that's prednisolone is the steroid tablets that we use when people exacerbate their asthma, and we try and prevent that for people from needing these things, because that's a marker of poor control, by using inhaled steroids instead. So that's our page, and the other thing we've been able to do is produce a benchmarking page, which Paul has been great at doing. And so it enables us to see what the trend over time is. This is 6 SABAs across the whole of Dorset. And for the last 3 years, we've been falling from 17% down to about 10%. And you can see across the 18 primary care networks that some are doing really well down here in terms of their SABA overuse. So this is some of my favourite primary care networks down here. And these are the ones that I'm not so keen on, that are over here, who have yet to do the work to reduce their SABA overuse. But that enables us to then compare these areas. And they're all falling by 2%, apart from this one, which can't get any lower than 1.2%. Use of salbutamol. And this is what that primary care network that I showed you that was the best performing, this is what it did. So 2 or 3 years ago, it did some real intense work in the primary care network to reduce SABA use and improve patients' overall asthma care. And you can see that they did brilliant work getting themselves down to 1.4%, and it's getting even lower. It's continuing to drop as they're getting people from the old-fashioned way of managing asthma. We use blue inhalers to a more modern treatment where they don't have blue inhalers and they use inhalers containing inhaled steroids to control their asthma. And there's lots of interventions that they did in order to produce that change, that improvement. So if we now compare our best performing primary care network, which is this one here, and now that's got one of these respiratory champions. So it's got a nurse in that primary care network who can do this work. And at the time we had a full-time respiratory champion. This primary care network was one of the least well-performing, and it didn't have a respiratory champion. So they'd almost eliminated SABA use in their primary care network. Most people had no SABAs at all. And correspondingly, they had a shift in their inhaled steroid use more at the right-hand side. This less well-performing PCN, they hadn't shifted their SABA overuse at all. They had inhaled steroid use, which was much less. And if we look at admissions to hospital, far fewer. You're talking about 1.8% of the asthma patients being admitted to hospital compared to 3.8. So over half the number of admissions to hospital, the rate of hospital admission from this primary care network, presumably because we're managing asthma better. And hopefully that's the reason, but also a reduction in prednisolone prescriptions. So that's nice to see, comparing those two polar extremes of performance. And indeed, there is significant variation in the this is hospital admissions for asthma, and this is the one that I just showed you, 1.3%. But the other primary care network that we showed you is somewhere around 3% admission rate. So it varies quite a lot. And what we're able to do is to show significant correlations between if you had high SABA use on this axis, you tended to have higher respiratory admissions, and if you had lower inhaled steroid use, you tended to have higher respiratory admissions. And there's a reasonably strong correlation there of R-squared value of 0.5 or so. But what was more convincing, because of course the key thing is this causal? Is this a causal relationship? The thing that's most convincing really is if you look at change. So if you look at the places where we managed to reduce SABA, did they have fewer asthma admissions associated with that? So over the last few years, there's actually been a slight rise in asthma admissions since COVID, because COVID led to quite a dramatic fall in asthma admissions. But they've been creeping up since then, but not everywhere. If you manage to reduce your SABA use, like this primary care network did, by 12%, then your admission rate didn't go up. Whereas those places where that didn't touch their SABA overuse, didn't manage to control their asthma better, didn't manage to, they had a rise in asthma admissions. And that's a reasonably strong correlation, isn't it? So we seem to have a chronological association, which implies causation. And we reckon that if all of Dorset was as good as the best primary care network, then we would be able to prevent 1,000 asthma admissions per year, and that would potentially save £1.5 million a year. So it's worth doing. That's great. And it's great that we've used data in order to improve care, and it's an ongoing piece of work. Of course, what's happened to our mortality? Remember where we started? Dorset's mortality was worse than than all the other ICBs in the southwest. Well, this is more up to date. So that data just went up to 2019. The data since then has been quite encouraging. So here we were toddling along at 3.5 deaths per 100,000 of the population. But we've dropped since we started doing all this sort of integrated, proactive work. We seem to have dropped and continued to have a lower asthma mortality rate. So potentially saving, maybe about 20 or 30 lives a year compared to what we were doing before. And we've joined the rest of the southwest, I'm pleased to say. So we're getting closer to Gloucestershire because, of course, they're the ones we've got to beat, though it's not a competition, of course. So population health management, it embraces these three priorities, very linked to the government's priorities: prevention from hospital community, prevention, and analog to digital. And data is really key to this, alongside leadership, team working, knowing your workforce, and accessing the workforce. And we were able to access up-to-date data. That data is updated every day, so that we could then identify variation and see the effects of our interventions and link that to reduced admissions. And it's associated with reduced mortality, though I'm always hesitant to say it's a causal relationship, but it seems likely that there's a link to improving care and reducing deaths. Thank you.
Thank you, William. That's a really interesting presentation, and apologies for the technical difficulties there at the beginning. Thank you so much. I'm afraid we're going to have to move straight into the next presentation, just because we need to make sure we finish on time. But as always, William and Paul will be in the people list. Please do direct questions about that brilliant presentation to them.